Hey guys, can you see me, hear me? Good evening. Kaise ho aap? So shall we start? How was your Sunday? What did you guys do on a Sunday? So let's hear from you. Just a little bit of relaxed talking. Good evening, Sogata. So what was your plan on Sunday? What did you do? What movie did you watch? Did you see cricket? What was your plan? What did you guys do on Sunday? Kumar, thank you. Nothing. Please don't say studying. Right? Studying, we'll do it every day. Sundays for play. Right? All work, no play makes everyone a dull person. Right? Good evening, Ankita. Fine. Hopefully, you guys will open up in the meanwhile. Enjoyed view through the balcony. Great, Shiv Kumar. You have an amazing view. Great. Perfect. So let's start. So we will try to complete the first chapter in this week. I might have a little bit of changes in the schedule because there will be a little bit of 3 days of Nischay batch. I'll try to complete the two things remaining. One is cellular aging and one is apoptosis. I'll definitely try to complete the both of them today in this week. And can we have a quick test after we complete this? I hope all of you guys are in the Telegram group. If not, do join. Either ping me on Telegram or on Instagram. I'll definitely help you in joining that. And we'll have a quick test after completing the first chapter of RRR, right? And maybe I'll conduct a session of MCQs on the same YouTube channel. We'll complete one and then do MCQs. Similarly, then we'll go to the next chapter. Fine. Okay, let's start. So today we'll be talking about pigmentation and calcium, right? Again, like I said, these are also intracellular accumulations which help us diagnosing a cell injury because patients don't come to us exactly at the time of cell damage, right? So there are two things in pigments. One is an exogenous pigment which can come from outside the body. One is endogenous which can be formed inside the body. Exogenous, will come to it very soon. Can anyone give me at least one example of pigments which can be formed inside the body? One example of an endogenous pigment. Anything? Any one example of an endogenous pigment? Skin, melanin is a pigment, right? Definitely. RBCs, when it breaks down, it becomes iron. Iron is a pigment. Copper is a pigment, right? So melanin is definitely one pigment, and there are many other pigments. We'll definitely look at them very soon, right? Exogenous pigment, there are very little exogenous pigment. One of the most important pigment is coal, right? Coal, when we inhale, all of us breathe polluted air. Whichever part of the country you are, there's no partiality. Whichever part of the world you are, except for few areas in the world, everything is polluted, right? So we cannot inhale that pollution. Coal is by default, everyone here will be exposed to, right? And this condition, we call it as an anthracosis. We will read more about anthracosis and its pathology, coal workers pneumoconiosis, very soon when we go to lung pathology chapter. As of now, when we inhale coal, it goes, right? So I'm inhaling coal, it goes into the lung. Which lymph node do you think will generally have coal? If I'm going to inhale coal, it goes to my bronchus, goes to the lung. There's a lymph node close to the hilum, right? Anthracosis can be very easily found near hilar lymph node, right? So hilar lymph node will have lots of coal pigment, even for your hilar lymph node, my hilar lymph node, everyone's hilar lymph node, fine? Is my sound, am I audible? Mosam, I think I'm audible. Can you just increase your volume if that is possible? Okay. So hilar lymph node, everyone's hilar lymph node will definitely be black in color, right? Next, exogenous pigment, like Shivakumar said, tattoo. Any of you guys have tattoo? Okay, must have just check it locally if your audios are better, fine? Okay, tattoo is definitely an exogenous pigment, right? Tattoo pigmentation can also be an exogenous pigment. Tattoo color will be based on what color you put. If you put a green ink, it will be green in color in the pigment. Black ink, brown ink, whatever color it is, right? I'm great, Sumit. Hope you're doing good as well. These are the only two places where pigments can come outside the body. This is not very relevant. One tattoo in the body will not do anything. If you're like David Beckham, then it's a problem. Entire body is full of tattoo, it's a problem. One or two tattoos is not going to harm much, right? Though there are risks, but it don't harm much, fine? Coal will definitely read when we come to lung pathology. Endogenous pigment is what we are much worried about. There are multiple endogenous pigments. Like you guys said, melanin for sure. I'll give you one example. I'm sure you must have read this in your first year of biochemistry. A patient with a black color pinna, black color nasal cartilage, black or brownish color intervertebral disc. Which disease is that? It's one of the metabolic pathway problems. Starts with A. Have you heard about alkaptonuria? The urine also changes color. That is definitely one type of an endogenous pigment. It's a pathological pigment. It's not seen in normal persons. Melanin can be seen in normal persons also, right? Perfect. Alkapnuria is definitely one of them, right? Great. So second thing, when we read about atrophy, right? When we read about atrophy, I told a pigment. What is that? When I told about atrophy, what is a pigment which will be accumulated in the lysosomes? All the cell debris will be as a pigment. What pigment was that? It starts with L. Do we remember that? Lipofuscin, right? That also is a pigment, right? So endogenous pigment, predominant of the endogenous pigment will be brown in color. Be it lipofuscin, be it iron, hemosiderin, be it copper, be it melanin. Melanin is also a brown color pigment. It's not a black color pigment. When it's concentrated, it gives black appearance. We were called as brown people by the Britishers, right? Brown color is the melanin pigment. When it's very concentrated, it looks like an African person, black in color, right? Perfect. So now I'm going to ask you a simple question which we read in the previous class. If everything is brown in color, can I differentiate each of them in light microscopy? Like when I look at a brown color, will I be able to say it's hemosiderin or melanin or copper or lipofuscin? Nachi will definitely take care of that. We'll have Foray series 1 month before the university. We'll take care of that. Don't worry. We can't, right? If we cannot do that, what's the next step? If I cannot diagnose or differentiate something on a light microscopy, what is the next step? What's the next step? What do? We always do a special stain, right? In other words, the only way to differentiate whether it's melanin or a hemosiderin or a copper is a special stain, right? Again, I need a utility so that I can remember the special stains, right? Perfect, great. Now, I'm just going to talk about a clue how to identify the pigment and few conditions where I can see the pigment, right? Lipofuscin is also called as an wear and tear pigment, right? It's wear and tear pigment. That's one more name for lipofuscin. This can definitely come in a viva. That's a wear and tear pigment, right? Lipofuscin we did read in atrophy. Can I say a person who is very old, there's more chance of atrophy? When you become like 80 years old, will your muscle atrophy? Will by default, right? So can I also say there's also a pigment seen in old age condition? It's not a pathological pigment. It's a pigment seen in cells aging. Okay, when a cell aging happens, it's a pigment seen there, right? A question says a 80-year-old person cardiac muscle shows a brown pigment. Think of lipofuscin. 80-year-old, the most important thing is it's an asymptomatic condition. This is not a pathological thing. When you, me, everyone in the world becomes older, the color pigments will accumulate by default. Like your graying of hair, this happens. It's an asymptomatic condition, right? How do I identify clues? Clue is very simple. It will be in paranuclear location. I do have a stain for this. I'm not telling the stain because it's not a pathological thing, right? It's not pathological. No one is going to remember for a long time. It's useful for viva, that's all, right? So this is an image from Robbins. What is the structure? The blue color structure. Is it nucleus or cytoplasm? We know the basics, so obviously we'll identify the blue color is the nucleus, right? And everyone here can easily identify there's a pigment just adjacent to the nucleus on either sides of the nucleus. On both sides of the nucleus, we call it paranuclear pigmentation, right? Perfect. Robbins also has an electron microscopic image. There also you can see the pigment on either sides. In electron microscopy, this looks black in color or an electron dense color. Fine, perfect. There's nothing much more to remember in lipofuscin. Old age pigment, pigment of cell injury, pigment of wear and tear in paranuclear location, right? Next is go to melanin, right? Clues. One, it's a brown pigment. If it's skin based, I'm not exactly saying epidermis, I'm saying skin based, right? I can have a melanoma, which is a malignancy, which can be also in the skin. We have something called a nevus, which also is it's a tumor of the melanocytes. Again, a skin based. If it's skin based, that's a clue to say, okay, it could probably be melanin. It's also brown in color, right? And the next thing is stain. The stain for melanin is Mason Fontana. Mason Fontana is a stain which will be positive for melanin. That's, I want you to remember, this has come in an exam previously. If something is positive for Mason Fontana, which means the pigment is melanin, right? Conditions where you can see melanin. I can see them in normal skin. Which layer of skin you'll have melanin? Melanocytes or melanin? Anyone? Let's see how good you have your physiology. I'm sure it should be pretty good, right? You will see them in stratum basale or stratum germinatum. The lowermost layer of the epidermis is where you see the melanocytes or the melanin pigment, right? So it will be normally seen in the stratum basale or the stratum germinatum of the epidermis. When it goes above, we won't have that. Yes, Jane Medical, in epidermis, in that which layer, right? It's stratum germinatum is where we see them, right? Perfect. In other conditions, I have a condition called as nevus. This is a benign tumor of melanocytes. We'll see what is benign malignant very soon when we go to cancer, neoplasia chapter. And we have melanoma. Melanoma is a malignant melanoma. It's a malignant tumor of melanocytes. These are a few basic things which I want you to remember. Nevus, every one of you has. All of you have moles, tiny moles. The technical term for mole is nevus, that's all. Nevus in singular, nevi in plural, right? Nevus is nothing but mole. All of us have benign tumors of melanocytes. Don't worry, it will not become malignant. Because we are Indians, the biggest advantage what we have is melanin. We are the only person who in the entire world has an advantage, and we put fairness cream on it to make it white, right? Melanin is an UV protector. Melanin protects you from cancer. Foreigners don't have melanin. That's why they have cooling glasses. They don't have melanin in the iris also. What is your color of iris? Your color of iris is brown or black, full of melanin. You don't want a coolers. We are born with the coolers. We are in a different level, right? Foreigners want to have coolers because they have blue or a green color eye, right? That's an anatomical defect, and we call it beauty, right? Don't worry, we are very, very beautiful internally and externally than anyone else in the world, fine? That's about melanin, right? Then we come to iron or hemosiderin. Iron has two components. When I say iron, iron can be stored as two things. One is hemosiderin. I will write them. Hemosiderin most of the time is pathological. Can anyone tell me what's a physiological deposit of iron? Physiologically, iron is stored in a form in the duodenal epithelial cell. You must have read in your physiology. What's a physiological storage form called as? We call them as ferritin, right? Actually, I don't worry about ferritin. Like I said, if it's normal and it's not related to abnormality, we never remember that, right? Ferritin is there in the body. I don't care about that. My only concern is hemosiderin, right? Iron is said to be in golden brown color. You cannot actually differentiate brown color and a golden brown color. Let's be honest. It's brown color. That's all, fine. So obviously I need a color, right? Obviously I need a pigment or a special stain. The special stain here is Pearl's Prussian blue. Okay, Pearl's Prussian blue is a special stain useful for detecting iron. This we will read in multiple places when we come to systemic pathology, when we come to hematology. Wherever iron is involved, Pearl's Prussian blue will be positive for. And what will be the positive color? Special stains are very, very easy. Blue color is positive. Yesterday we read about oil red O, Sudan black. Both of them stains what? Do you remember? Oil red O and Sudan black, both of them stains fat. Oil red O, Sudan black, right? Like that, Pearl's Prussian blue. I can either call it a pearl stain or a Prussian blue stain. Both of them will stain iron into blue color, right? Perfect, great. So now, where do I see them? Just I am mentioning few conditions. Hemosiderosis, where I have an excess of iron, or an hemochromatosis. We will learn the difference of hemosiderosis and hemochromatosis when we go to systemic pathology. And I have excess of iron. That's a condition. Second, have you had a bruise? Someone bites you or someone punches you. Have you ever had a bruise? You fell down, someone blunt injury. If you notice the bruise over the period of time, it will become slightly reddish to brownish color, then green and everything, right? Whatever you read in physiology and biochemistry, bilirubin, biliverdin, hemosiderin, everything you can identify in a bruise. It will change color, right? That's a classical example. A simple trauma where there's a closed injury, a bruise, actually will have hemosiderin. But I don't want to take a biopsy. I know for a fact it is that. Right? I know for a fact is that. That's also I'll have it, right? And there are a few more conditions. We call it in heart failure cells. Heart failure cells are something seen in lung, which are iron laden or hemosiderin laden macrophages. We will read them when we come to the 4th chapter of hemodynamics, right? It also is there. All these are applicable in systemic pathology. Only now I want you to remember iron, brown color, positive for pearls. If it's positive for melanin, positive for Masson Fontana, melanin, brown color, right? Then we can easily identify what is the diagnosis. Last but not the least, copper. Okay, Copper is not there in your books, but I want to add here itself because copper is also brown in color. Okay, it's brown. Copper is there in different parts of Robbins, maybe not in this exact part, right? Copper, stain of copper. I have two stains. We'll just at least remember one, rhodamine or rhodanine. M-I-N-E, N-I-N-E. Both are acceptable spelling. One is a stain, one is a procedure, right? And then we have one more stain called orcine stain. These are two different stains, rhodamine and orcine. Both of them will stain copper, right? If you remember your biochemistry copper metabolism, do you know any condition where you have a defect in copper metabolism? The disease starts with W. Does it ring a bell? There's a disease which starts with W. Does it ring a bell? Wilson's disease, right? That's a classical condition, right? So one condition where you'll have copper excess in copper metabolism is Wilson's disease, right? Perfect. So again, when we go to systemic pathology, liver pathology, we may touch base on Wilson's disease. So if let's assume I have a question to you, 40-year-old person, liver failure, microscopy of the liver biopsy shows brown color pigment, okay? And the pigment is positive for Pearl's Prussian blue. What is your diagnosis? 40-year-old, liver failure, liver biopsy, brown pigment, pigment positive for Pearl's Prussian blue. What is it? It is hemochromatosis, not Wilson's, right? It's iron. Okay, it's hemochromatosis, right? That's how you have a clinical scenario question. When we go to NEET PG next exam, we'll do MCQs for sure at the end of this exam, so the end of the first chapter. So we apply these terms. It's a fact. Fact is not useful for me. We apply the fact and we come to a diagnosis, right? Perfect. So these are the pigments which I want you to learn. And let's come to calcification. Right? Calcification. There are two things in calcification, right? Have they taught you in your college about calcification? No. Have they taught you about calcification? They taught you. You must have definitely at least read these two terms: dystrophic calcification and metastatic calcification, right? Like I said, everything in medicine and everything in pathology is about the terminologies, right? Dys means abnormal. Trophy means tissue or cells or whatever it is, right? So it's an abnormal tissue. Okay, growth, abnormal growth or an abnormal tissue, right? Let's assume like that, fine. So dystrophic means the tissue is abnormal, right? It's in the term, everything is there in the name. What do you mean by meta? Great, Punit. What do you mean by meta? Meta means change. So metastatic means change in homeostasis of calcium metabolism. That's all, right? So metastatic means it's change in calcium homeostasis. I'm sure you guys know what is homeostasis, right? You must have read in your physiology. Homeostasis is nothing but maintaining the normal levels of your whatever it is, sodium, potassium, whatever it is, it's maintaining the normal levels. That's homeostasis, right? Here you'll have change in the calcium homeostasis. That's metastatic, and dystrophic is nothing but an abnormal tissue, right? Now I just want you to listen to these things and answer me one by one. I'm going to have a calcification in the tissues, right? Calcium is going to deposit in the tissues. What change will cause them to deposit? Hypercalcemia or hypocalcemia? It's metastatic. What change will cause them to deposit? Hyper or hypo? Definitely hyper, right? Only when it's more, it gets deposited. Perfect, right? Now I'm just going to have a quick table to remember both of them. So metastatic calcification, you guys said that. I'm going to write whatever you guys said. I'm going to have increased calcium level, or I'll have hypercalcemia. Right? It's metastatic, it's changed, that's all. Perfect, right? Now let's go back to your physiology again. If it's hypercalcemia, can anyone tell me what hormone is responsible for calcium metabolism? You must have read in your first year physiology. Which hormone? It is parathormone, right? So let's say I'm having a condition with an hyperparathyroidism, that's more parathormone, right? Can it cause hypercalcemia? The primary problem here is hypercalcemia, that's all, right? So when I have hyperparathyroidism, can it have hypercalcemia? That's all. So I know the etiology. Just one word is enough for us, right? So here the primary problem is increased levels of PTH. Parathormonous PTH. In other words, hyperparathyroidism, right? So where all I can have hyperparathyroidism, will come to that Nishan, the vitamin D as well. Where all I can have hyperparathyroidism, the first thing is parathyroid adenoma, which is a tumor of parathyroid. I can have hyperparathyroidism. Okay, parathyroid carcinoma or your parathyroid hyperplasia, that also can happen. We will read about hyperplasia and adenoma when we go to endocrine chapter. Then also I can have increased parathormone, right? Perfect. So ultimate premise is I should need hypercalcemia, right? One can be due to parathormone dysfunction, right? Now tell me which organ comes to your mind when it's extremely rich in calcium. Whatever comes to your mind, definitely one organ should come across your mind, right? Something which is extremely rich in calcium. What is that? Obviously bone, right? Okay, so I'm going to have some random disease which is going to reabsorb bone very fast, which is going to remove the calcium from the bone very fast. Is there a possibility that serum calcium level can be elevated? Sarcoplasmic reticulum also, but reticulum is different, right? It's for contraction. Bone is something which has more. Osteoporosis will not happen because osteoporosis is a very slow process, right? So when I have anything which is fast resorption, right? We have bone resorption. Any disease which will resorb the bone faster. Example, you have your metastasis. We'll read about that in cancer. Metastasis to the bone. We have a bone marrow or a plasma cell tumor called as an multiple myeloma, right? It's a tumor of plasma cells. We have a multiple myeloma or bony metastasis. It will automatically increase the bone resorption, right? There are many more things we will read in the endocrine chapter, or we will read when we come back to your orthopedics in your final year. Fine. Next, someone said vitamin D intoxication. When there's more and more vitamin D, obviously the calcium levels is going to increase, right? So vitamin D intoxication can also happen, right? So all of them, primarily what they're going to do is increase the parathormone, sorry, increase the calcium levels. That's all. There are few random diseases called as a milk alkali syndrome. Renal failure is what will cause parathyroid hyperplasia, so I'm not talking into it, right? So all these will cause primarily your increase in your calcium levels, right? Now let's go to the characteristic features. Okay, put your pens down, listen to me slowly and answer my questions. So here I'm having excess of calcium in the circulation, right? Accepted? Accepted. So this calcium should deposit in the tissue for us to have calcification, yes or not? Or if the calcium is in circulation completely, will it form a calcification? In blood, a liquid, I cannot calcify, right? It has to deposit in the tissue, right? Now I have two types of vessels. One is a vessel like aorta, where the blood is flowing very fast. One vessel is like a capillary, where the blood is a little bit sluggish. Where do you think calcium can exactly go outside, or exactly it can go easily? In an aorta, where the flow is very fast, it can go outside easily, or like a capillary, it can go outside easily. It's simple, basic common sense, right? It's capillary, undoubtedly capillary, right? So in a capillary rich structure in the body, can I say it can easily form calcification compared to heart and aorta? Just a comparison? Yes, perfect. Now you guys are going to tell me your beautiful knowledge of anatomy and physiology. Which organ comes to your mind when you have lots of capillaries? One organ especially, you must have drawn cup noodles, right? I'm sure you must have drawn this structure in your physiology. A cup and a noodles. That organ has definitely capillaries. What organ is that? Glomerulus? Kidney? Obviously. So in this condition, I will have renal calculi. That's your stone formation. That's one. Can I also say lung is full of capillaries? Lung parenchyma, like Sunny said, undoubtedly full of capillaries, right? So where all I have the calcification also is characteristic. I won't have calcification from head foot to foot. I'll have in few particular organs like lung, like renal stones. Lung calcification will not be symptomatic. It's a calcification there, that's all, right? Next question. Tell me, when do you think calcium will get deposited, or when do you think calcification will happen? When it's a mineral calcium, or it's calcium phosphate, calcium carbonate, when do you think it will happen? Where there's more chance, if it's just a mineral, or if it's a phosphate carbonate, stones, where do you think it will more get deposited? Obviously when it's a salt, deposition is more easier when it's a salt than a mineral calcium, Ca2+ versus Ca phosphate. it'll get deposited easily, right? So can I say when the calcium in the vessels goes through my GI capillaries or GI arteries, there's a very high basic pH. There's lots of bicarbonate secretion in the pancreas. Yes. Is there a possibility to form carbonate, bicarbonate there? Yes. So GI calcification also is common, right? GI calcification is common because it can form salts here. The salt formation is more here, right? So the salt formation is more, there's more chance of it to get deposited. I am not telling that in other places it won't. These are preferred location, right? Next, only one information, then we'll go to dystrophic. There's one more classical finding of metastatic calcification. We all have read about just calcium as a salt. Now, my blood has excess amount of calcium. Have you read that in your physiology? Calcium is a neurotransmitter. Am I right in saying that? Calcium is an excitatory neurotransmitter, right? So if calcium levels become more in blood, will there be psychiatric disturbances? You will have psychiatric disturbance, right? Though it's not due to calcification, psychiatric disturbances, the patient might be a little bit anxious, anxiety, mania-like symptoms, all these will predominate in this patient. Ultimately, it's calcium, just calcium, right? It's change in homeostasis of calcium, right? You just remember this. Your biggest concern is I'm not able to memorize, right? Memorize the name, rest everything will form it. Create a circuit in your beautiful brain, right? Tiny links. Tell me honestly, how many of you like gossips? Tell me honestly, how many of you like gossips? We'll have no gender bias here. Men, women, child, elderly, adult, no age bias. How many of you love gossips? I love gossips. I'll be very honest about it. Everyone loves gossip, right? If you say you don't love gossips, you are lying. That's all. Everyone in the world loves gossips. The reason why you like gossips is your brain craves for it. Because when you form neuronal connections, it will be played back again and again and again and again and again. You will never forget. That's why love failure is very difficult to forget. Because you've created memories, it's very, very difficult to erase it. When you can create memory out of love Robbins, love pathology, love medicine, you can create a memory which you'll never ever forget, right? That's all. It's memory. So what I create is, I create a link from the name to the problem. I create a link from the problem statement to my etiology. I create a link from my etiology to my symptom. One link which is missing is treatment. I'm not going to talk to you about treatment. There are beautiful teachers better than me who will talk to you about treatment, right? Create a link so nothing will become difficult for us, fine? Okay, let's go to dystrophic. Dystrophic calcification basically means an abnormal tissue. That's all, right? Yes, Punit. It's abnormal tissues. That's all. So here, tissue is abnormal. What do you think will happen to serum calcium? Will serum calcium be normal? Absolutely, right? Serum calcium will be normal here. The problem here is not in the calcium metabolism. The problem here is in the tissue, right? I have in both dead tissue and degenerating tissue, I'll have that, right? Okay. The reason why I'm very confident that in dead tissue it will happen is, what's the most common ion in irreversible cell injury or necrosis? You guys know that. The most common ion is calcium, right? That's why we had saponification and the omental calcification in fat necrosis, right? So by default, a dead tissue which is chronic over the period of time will calcify. That I'm going to call it dystrophic, abnormal tissue, dystrophic calcification, right? Few examples. One is cardiac calcification, right? Cardiac calcification by default is abnormal. Cardiac calcification in the valves, the image of Robbins talks about that in old age. Okay, I'll tell you why this will come under dystrophic. You might wonder what happens in a heart, what is dead in a heart or degenerating heart in an old age, right? Heart every single minute pumps for 60 to 70 times, right? If there's no palpitation, right? Every second the heart pumps, every second the valve keeps on moving and closing, up and down and up and down. Is there a possibility that can be wear and tear? A tissue functioning non-stop, even when we sleep, up and down, will have wear and tear, right? So in old age, tiny amount of degenerated tissue will stay there. I cannot stop it. Your heart also will become calcified. My heart also will become calcified, right? This is an image from Robbins. This is the valve and these are the calcific tissues, right? There are calcific tissues here and there. This is your valve. You can see the valve leaflet which has been closed. That can by default happen. It will happen by default, fine. So that is a cardiac calcification which can happen in old age. The same old age calcification can also happen in vessels. Because vessels, like heart, every second pulse up and down because the waves go there, right? So vessel calcification also happens. This we call it Monkey-Burg's medial sclerosis. This is a vessel calcification. Have you heard this name in your physiology? You might have. Okay, that's a Monkey-Burg's medial sclerosis, a vessel calcification, right? Now let's come to Psammoma body. I'll fill this here. I just want you to remember 3 things in Psammoma. We'll remember about all the 3 things in Psammoma soon, after remembering the concept of Psammoma, fine? If they have taught you about this in your college, Psammoma body will be there in one tumor. What tumor is that? What comes to your mind? What tumor will have Psammoma body? If they have taught you in your class, this tumor called as an papillary carcinoma thyroid. That's what Robbins talks about, right? In case of papillary carcinoma thyroid, you will have Psammoma body, right? Perfect. Dr. Puneet has said papillary carcinoma of kidney. That also, right? Lungs, perfect. So in Psammoma bodies, generally Robbins in most of the textbook talks about papillary carcinoma of thyroid. Okay. So what we are going to read here is, don't memorize Robbins, right? It's thyroid cancer that is there for me by default. But the problem here is not thyroid. The problem here is a papillae. Papillae is a problem. That's why you have Psammoma bodies. Let's explain that, right? What do you mean by papillae? Can anyone define a papillae? Papillae you must have read in your first year, right? Define a papillae. Whatever you know. If it's wrong, it's wrong. That's all. Don't worry about making mistakes. Define a papillae. Papillae is a finger-like projection, right? That's a papillae, right? Perfect. Projection is a right thing. I'm not saying it's wrong, but it's a little bit incomplete. Bulging, I will not call it a papillae. Bulging, I might use the term swelling, right? Leaf-like structure, generally no. Papillae is this, finger-like, right? It's a finger-like structure, right? So I have a finger-like structure. That's actually not the complete definition of papillae. A finger-like structure with a central vessel, okay? That's what a papillae means. It's finger-like with a central vessel. If there is no central vessel, we use the term villi. Villi is different from papillae. Puneet, okay? Villi does not have a central vessel. Papillae has a central vessel, right? That's very, very unique here. Let's zoom this a little bit. Okay. Now tell me, can I say this area, the tip of the papillae, blood supply is less? Is that statement right? The tip of the papillae, will the blood supply be less, or it will be same like the base of the papillae? It will be less, right? The tip has less blood supply. When the tip has less blood supply, can I say there's a chance the tip can undergo ischemia? Is there a chance? Definitely, right? The tip of it will definitely undergo ischemia. Is there a possibility of infarction on the long term? Possible. If there is an infarct, can I have a necrosis? Possible. Now guys, tell me, what's the most common ion in necrosis? It is calcium. So by default, it's a tumor. It is there for years together. Can this calcium cause calcification? And I'm going to call it a Psammoma body, right? Psammoma means sand. It is gritty like a sand. If something is calcified, I rub the area, it's gritty like a sand, so we call it Psammoma bodies, right? So the problem is not thyroid. Like Dr. Puneet said, whatever papillary tumor it is, be it breast, be it kidney, be it omentum, be it your head, neck, anywhere in the body. If it's papillary tumor, I will have Psammoma bodies. It's not about papillary carcinoma thyroid alone, right? Now, let's write that down. Tumors which can have Psammoma body. First, papillary tumors. So how do I know which tumor has papillae? Human beings and medicine is very, very, very simple. If a tumor in microscopy has papillae, the name will have papillae in it, like papillary carcinoma thyroid, right? If the name has papillae in it, then microscopy will have papillae. Or if the name has serous in it, microscopy will have papillae, right? by default, it will have papillae. There are tumors called as serous cystadenocarcinoma. If the name has serous, microscopy will have papillae. If microscopy has papillae, they will have Psammoma body. Anything, Punit. There are many papillary tumors, all of them, right? Now let's come to next thing of Punit's of meningioma, right? Second thing is your world appearance. This appearance called as a whirl. The same concept, right? The center of the whirl, the blood supply will be less because the blood supply comes from the periphery. So once it reaches the center, the blood supply becomes less, right? So you'll have less blood supply. When there's less blood supply, by default, I'll have chance of same again, ischemia, infarct, necrosis. Necrosis, the most common ion is by default calcium. When it's calcium, by default, it can cause Psammoma bodies. So next is any tumor with whirled appearance will have Psammoma bodies, right? Punit, not every mesothelioma, papillary mesothelioma. Only papillary mesothelioma can have Psammoma bodies, right? I'm sure you are coming from the PSM square, right? PSM square is for an exam. It's not for concepts, right? So only which is papillary will have. Papillary somatocytoma will have. Not everything else. Okay, Ram Sarji. Okay, so here again, whirled appearance are there in two tumors. One is meningioma, other is leiomyoma. Fine. So these two will definitely have Psammoma bodies, right? So ultimately, we'll try to remember this because this will stay with you for a very long time. It's just papillae. So what I want you to remember in Psammoma bodies is tumors with papillae in the name, papillary tumors, tumors with serous in the name, serous tumors, and tumors with whirled appearance. If they have whirled appearance, they will have Psammoma bodies, right? I just want you to remember this. That's all, right? That's how Psammoma bodies are formed. That's how Psammoma bodies will be, right? I am not telling you the mnemonic for the only reason the mnemonic is incomplete. Because one exam, they asked papillary custom of thyroid. So you remember papillary custom of thyroid. I need not ask the same thing in the next exam. I will change the question. This is not NCRT again, right? It's a big human body. Then you should not say it didn't come in. We have not studied that. Any papillary tumor will have it, fine? No, Punit. That's only for thyroid. It is because of it's an artifactual finding, right? Okay. So now the finding. The microscopy of dystrophic calcification or microscopy of Psammoma. Okay. We have to understand why it is, right? Great Ayush. Okay. See, I could have easily made up this thing, right? Because it sounds interesting. There's a possibility that I could have just made up the story and telling you something, bluffing something. There's a possibility, right? Never trust anyone in life. We practice evidence-based medicine, right? If this is true, my evidence should be like that. If whirl is causing the calcification also should be whirled. Can I say it's whirled? It's whirled. There's a meningioma calcification. It's like a whirl because the whirl causes the calcification, right? So by default, whatever we saw is right. Psammoma bodies will most of the time be whirled in appearance. It's whirled. Papillary also tip. I'll have the calcification. I look at the papillary from the top. I won't look at the papillary sideways. In the tip, it looks like a round structure. That's how calcification looks like, right? So most of the Psammoma bodies will have a whirled appearance and they'll be blue in color. They'll not be pink in color, right? What's one more thing we know it's blue in color? What's one more thing we know it's blue in color? What's that? Nucleus, right? So can I say, is there a possibility a pathologist can differentiate a nucleus versus the calcification? I can't. So if I can't identify them, how do I remember them? What do I do next? Special stain, that's all, right? So if I cannot identify, I by default cannot differentiate this blue from a nucleus blue, though I can, but I need a special stain. Okay, this is one of my seniors who told me. I'm just telling that easy way to remember. Any clues, mnemonics is not mine. I copy from someone else. I'm not that creative to create a mnemonic, fine? So let's say write it as KALCIUM. Instead of calcium, let's write K, right? K stands for cosa. The stain is 1 cosa. AL stands for one more stain called alizarin red. Okay. Both are stains of calcium. Voncosa is the most common stain used. Alizarin is a very good stain, but very, very expensive. It's not used in the lab. It's used only for research purpose. Voncosa is used from every lab from Kashmir to Kanyakumari. Other things we don't have. Great, Punit. Tell to your juniors to read Robbins because that is the base. Fine? Okay. Perfect. So that's about calcification. So we are done with both dystrophic, metastatic calcification and also about pigmentation, right? Any doubts? Do let me know. If not, let's call it a day. Yes, Litika, tell me. Okay, if there are no other doubts, we'll call it a day. See you guys soon. After completing this, we'll do it. Thank you, Shiva. That's auramine rhodamine. Okay, that's a fluorescent stain. That's a different thing. That's a different thing. Litika, wherever you have necrosis, long term you'll have it. Papillary structure is something where necrosis is more common and it can have. Any tumor with necrosis will have calcification by default on a long term. Fine. Okay. Thank you guys. I hope it's clear. Fine. Okay. See you tomorrow. Bye bye.